Pakistan. Bismillahirrahmanirrahim. I think it's a time to start our presentation. We are already late. There is slight change in the presenters. Change in the sense that Professor Masood Ahmed, who is the principal presenter of today's session, has given me a brief time to show a slideshow how to perform an ECG. So that will bring you the context of ECG, how to do it, how to interpret it. There's a brief slideshow. I will not take more time. Let me start my presentation with this picture. Can anybody recognize who is this gentleman? Look at the picture. There's a person sitting. His hands are immersed in water, both hands and one foot, and there's a big machine which is recording something. There's a very famous name in the history of ECG. Although the history of ECG is very prolonged, this is a picture of a person named William Anthon. So he was the person who laid the foundation of modern ECG. He was the person who described for the first time the P wave, Qrs complex, the T wave, and these are the various deflections of ECG. And he also described with his ECG different features of cardiovascular diseases. And for this great achievement, he was awarded Nobel Prize for the category of Physiology and Medicine in 1924. This is one important aspect of our CME, that is M.R.C.G.P. International. So this presentation of ECG is very, very important from M.R.C.G. point of view. Let's recapitulate what is M.R.C.G.P. International. South Asia, as we know, it has got two parts. The part one is MCQs and extended matching questions, which will be held in Pakistan. The part two, which is OSCE, that is objective structured clinical examination, which will be held in Bangladesh for the first year. So the importance of ECG is that it is relevant to both parts of exam. The part one exam will be of 3 hours, and there will be 200 questions, called items in the terms of exams, and these will be single best answers or extended matching questions. So both of these combined will consist of 200 questions, and we will have to solve all these questions in 3 hours. Again, as I said, it's important because ECG will be assessed in both in part 1 and part 2 of M.R.C.G.P. International. And I'll briefly describe how the questions will be phrased and how this can be asked in M.R.C.G.P. Just to give you one example, how, like, you may get a question like a 26-year-old banker has come to you with complaints of palpitations off and on, not related to any activity. He does not smoke and he walks 30 minutes every day. His examination is normal. You advised ECG just for reassurance and you found this. They will not give any details, what is the P wave, what is the QRS, nothing. Just they will leave you with this ECG so that you see it interpreted. Those who understand ECG will choose the correct one and correct answer. Those who do not understand ECG will most probably choose a wrong answer. So I will not ask you what is the question. So just to give you a flavor that this can be asked. Can anybody tell briefly just one point in this ECG? Anything significant? One. So you will see this. Remember this ECG. I think you will see this ECG when the Professor Masood will discuss ECG. This is slides running on the PowerPoint. This is called delta wave. You'll see this. What is delta wave? And you can write this question. What is delta wave? Let's go to another scenario where a 55-year-old smoker has come to your clinic with history of cough for 1 week, He has complaints of chest pain mostly after coughing. There is no history of diabetes, hypertension, dyslipidemia. His family history is positive for ischemic heart disease. The only available ECG shows maybe something like this. No, not like this. Oh yes. No label, nothing. So this is a scenario where LBB, so LBB, when LBB is there, it's very difficult to interpret the ischemic changes, and they can ask you certain questions like this. What will be your management as family physician, not as cardiologist? So they are very tricky. They can make some tricky things like start aspirin and nitrates, advise rest and refer for cardiologist for further evaluation, because you may be thinking that you may need echo or thallium or anything. Reassure that these are old changes is one possibility. Refer to emergency for streptokinase. Those who think there is acute MI may refer the patient for streptokinase. For pacemaker, those who are not familiar with the rhythm part of ECG. Direct for angiography, who are not aware of the non-invasive things. Yes. Another scenario, a 23 years old controlled asthmatic woman currently on no medication has come to your clinic with complaints of palpitations. Her pulse is fast. The rest of her history and examinations are unremarkable. She is concerned as one of her uncle died of heart disease. You advised ECG which shows something. So they mix something, the important clues, asthmatic, palpitations, normal history and physical exam, and a concern or anxiety, a fear of heart disease. So there are mixed scenarios. They can give you this ECG. Those who know what is ECG, how to interpret it, will probably pick what is this. I will not give you the answer. Let's go to the options. So I'm just making you feel how easy or how difficult M.R.C.G.P could be if you do not understand or do not know how to interpret things, because the level of questions is not factual. They are not there to check factual knowledge. Itne points हैं, ये 10, give us 10 reasons of this, write 3 causes of certain thing. They are not checking this. They are checking a level higher, how to apply knowledge. So they are not checking what is your knowledge, how you apply your knowledge. Okay, you want to go back to ECG. Acute fast heart rate in layman terms. So those who know what was in the ECG can probably choose the right one. Wow, that's the clue. That was the clue. You people who do not know that the beta blockers are contraindicated in asthmatics may choose the propranolol option. So those who know will, although the ECG was not related to propranolol, the history was related to propranolol, because in history it was said that the patient is asthmatic. Number 2, so one option is out. Refer to cardiologist for further evaluation. As family physician, a young woman comes to you with a fear and something. Do you need to refer this patient to cardiologist? Advise hemoglobin and thyroid function test. Those who know that such ECG can be found in certain medical conditions, advise hemoglobin, thyroid function test and propranolol for symptomatic relief, just to trap the candidate. Reassure her and advise her low dose tricyclic. Those who think that the patient has anxieties, let's treat the anxiety with tricyclic antidepressant, without knowing that it can cause tachycardia, further aggravate the situation. This was all about part 1. So you will find more or less similar MCQs with changes. Let's come to the part 2 of M.R.C.G.P. There again ECG may be checked. Like you may have a station where there will be a patient lying on the bed, and there will be ECG machine lying there and all the things required, and the candidate may be asked to perform ECG first and then interpret the findings of ECG and educate the patient. So they may check 3 or 4 things in one station, like doing ECG, interpreting ECG, then communicating the findings to the patient. Let's come to the slideshow, which is the main purpose of this presentation. ECG machines are different models. The new ones, they're automatic, the expensive ones. I've chosen some simple machine which is available in most of the places. It's a simple machine, a few panel of buttons, and this is a slit from which the paper comes out when you start taking ECG, and the power switch is almost there in all ECG machines where you can switch on and switch off, and there is a panel of buttons from which you can choose the leads. This is a magnified view of the panel of leads. Like you see, there is a button of auto start, manual, and for manual you can choose between the lead 1, 2, 3, AVL, AVR and AVF, V2, V3, V1, V2, V3, V4, V5, V6. From these buttons, again a simple one. If you have some idea, you can then sort out the leads. So we know that there are 12 leads in ECG, so there will be 12 wires. No, not 12 wires. Wires are less. 10 wires. So if you just sort out the chest leads and the limb leads, and you see that there are different color codes, international codes, red, yellow, green, black, and also a range of colors for the chest leads. And these are there to these are guidelines almost common to all ECG machines. Like the red one is for the right hand, easy to remember. The yellow for the left hand. Green, so this is green one, not shown very well in our slides. This is the black one for the right foot. Before you attach leads either to chest or to limbs, you must apply the electrolyte jelly. It's jelly available, and this is there to give a good conduction from skin to the leads. And the leads, there are various methods of attachment leads. A very common one is a gadget with a hole in which you fix the wire, and then you turn the nut to tight it. So these should be very tight to give a good result. Then how do you start ECG? You must know your landmarks. As you saw in the previous film, that the limb leads are easy to attach. You know the colors, you attach them. Now come to the chest leads. You start by identifying the angle of Lewis. We know that where's the angle of Lewis, and just addition to this is the second intercostal space, and then you have third and fourth. And you apply your jelly on the right. You start with the right side, just adjacent to the angle of Lewis, just below the angle of Lewis, the third space. We know that the angle of Lewis is at the level of second intercostal space. We start ECG as one space lower down. And you applied one lead. This is V1, right fourth intercostal space. And the V2 is just on the opposite side of sternum, same fourth intercostal space. Do not put the lead 3 first. Those who are expert can do it, but for us, if you remember, then we lead V4. V4 is right at the apex, usually the fifth intercostal space in the mid-clavicular line, and the V3 is put in between V2 and V3, and the V4 is in the anterior axillary line at the level of pectoralis major muscle. Then this 5 is mid-clavicular line, and you see that the V4, V5, V6 are almost at in one line. So from top it looks like something like this. So mid-axillary line. So then how to put these leads? Usually there may be leads which stick on the skin, but usually with a rubber bulb which creates negative pressure, and there is the bell which attaches to the skin. You start by pushing it, making a vacuum, then attaching to the skin and leave it, and you check. So is a negative pressure, it actually sucks the skin. Then once you do ECG, after all these things, either manual or automatic machine, you must clean the patient because you have put the electrolyte jelly on the patient. This is the place where paper, you must check that there is adequate paper in your ECG from time to time. Then you can take care of your leads by hanging them in a secure place. I will end my presentation with a technical error which we all see in television and movies. Everybody has seen a flat line in ECG in movies where they show that the victim has died, or the hero has died, the villain has died. So they show that a flat line as a symbol of death. And then you have also seen that when the flat lines, people are defibrillating the patient. It's very common, it's seen to create drama. So the error is that the defibrillation is used for fibrillation, pulseless tachycardia, and asystole, the flat line, is not reverted by, if I am right, asystole, if I do not defibrillate asystole. These are the person, the volunteers who volunteer for ECG, and the technician who helped me in ECG. Thank you so much. Now I'll invite Professor Masood Ahmed to start his PowerPoint. Sir, मैं करता हूँ, मैं बैठ जाता हूँ.
Alhamdulillah Rabbil Alameen, As-salatu was-salamu ala Rasulil Kareem. I'm very grateful for your kind invitation to be talking to you on the ECG tutorials. Invitation to be here today to talk to you on the ECG tutorials. Some of you might have been present in the presentation that I gave here in the past on the ECG tutorial. But before I get on to the ECG tutorials, I just want to issue a disclaimer that I'm just a cardiologist. I'm not professor at all. I've got no affiliation with any academic institution at present. So I'm very grateful for being called as a professor, but I'm not a professor. I'm just a consultant cardiologist. Right, I think you've had a good introduction to the ECG, how to do the ECG. Important thing is, I think there was one or two things that's probably not been shown to you is the errors in doing a wrong ECG, especially if there's a transposition of the leads, limb leads. If there's a transposition of the limb leads, you'll get a wrong axis, and you may interpret that as dextrocardia. So you have to keep that in mind, but we'll come to that later on. A good way to remember is that you start from the right side by putting the limb leads from the right side, and just remember the traffic signal: red, yellow, green, and black. So you go from right to the left foot. So right arm, red, left, yellow, then green, then black. So that's the way to remember that. Same way you remember the chest leads, that they are put as red, yellow, green, mauve, then again, I think it's written on that, but you basically go red to green again. Let's start next. The 12-lead ECG The 12-lead ECG basically is a representation of the heart's electrical activity recorded from electrodes on the body surface. This section, basically, we will be describing the basic components of the electrocardiogram and the lead system used to record the ECG tracing. What I understand is that I have to take you through the basic ECG interpretation skills, and then lead you on to common arrhythmias or common ECG abnormalities as you see in the clinical practice. Is that right? So just to start off with the common ECG interpretation and then take you through to the common abnormalities that you'll be coming across in your practice. This is the, I can hold it in my hand, I think that's probably better. Next. So this is the electrocardiogram. Basically, it's just to make it clear that the ECG paper is a grid paper. There's a grid on the ECG. And it is basically run through the machine at a speed of 25 millimeter per second. You can vary that speed, but remember that the ECG paper, it goes through the machine at a special speed, and the common speed that is selected, the standard speed that is selected is 25 millimeter per second. So in 1 second, it will go through 25 small squares, 25 small squares. Now, this 5 squares, 1, 2, 3, 4, 5, and that was a bit better. If you can just, yeah, that's better. 1, 2, 3, 4, 5 small squares, they are basically grouped together as a big square. So whenever you see an ECG, you'll see that small squares, and 25 of these small squares will be going through the machine in 1 second. And those, in order to identify them clearly, they are basically further divided into big squares. So you have 5 big squares, means in 1 second you'll have 5 big squares going through the machine. Similarly, the amplitude of the small square is 1 millimeter across. 1 millimeter across up and 1 millimeter across this way on the y-axis and the x-axis. So one small square is basically 1 millimeter squared, right? It's just a basic thing, a very basic thing. You'll come to that, the significance of that. So when we know that we are going through basically 25 small squares per second, you can count the number of beats in that time. For example, you have number of 10 small the Qrs complexes in 1 second, so that you can calculate the heart rate. If there are so many complexes in 1 second times 60, you'll have the heart rate. Now, this is time along the x-axis. This is the time, and that's the voltage along the y-axis. So when you look at this Qrs complex, this way you'll be looking at the voltage, and this way you'll be looking at the time. So the interval between this and this, you'll be measuring that, and then you'll compute it according to the speed of the paper. Now, small square basically is 0.04 second. Yes? If you multiply it with 25, it will be 1 second, because it is running at the speed of 25 small squares per second. So therefore, the one small square will be going through the machine in 0.04 second. In other words, 40 milliseconds. So remember that one, simple 40 milliseconds. Small square across is 40 milliseconds, and 5 big squares will be 200 milliseconds. 40 milliseconds small square, and 5 square, these 5 squares will be 200 milliseconds. Now, ECG basically is, you have the nomenclature giving to the ECG. P wave is basically atrial repolarization. Atrial depolarization, you get this P wave. QRS is the ventricular depolarization. And ST segment basically is a period where the ventricle is in refractory period. And T is the repolarization, right? So therefore you have the whole electrical activity of the ventricle and the atria registered on the paper, showing as P wave, Qrs complex, ST and T waves, and U wave if the patient's got brady cardia, you'll see that U wave as well, which is always in the same direction as the T wave, but it is not commonly sought, it's not easily found. So we basically talk about P, QRS, ST, and T most of the time. The P wave is upright and leads 1, 2, and 3 in AVF. I'll come to that. Don't worry about it. I'll come to that during the course of the lecture. But you have to look at the polarity of the P wave as well, whether it is upright or it is downsloping, downright. If it's upright, it should be upright in 1, 2, 3 in AVF, because that's the cardiac axis coming in 5 o'clock position. Cardiac axis is from the right arm going towards the left foot. So therefore, the leads that are looking towards from that side, inferior leads, the cardiac vector is basically pointed towards that, and it will register a positive deflection. Can I just say one thing again? I'm sure you'll find part of what I'm saying, you might find it a little bit boring in the beginning, but don't get disheartened. You will easily pick up, you'll very easily pick up, and you'll start floating with the mainstream lecture very quickly. Just keep taking it. You'll get a repetition of a lot of what I'm saying at the moment, and don't hesitate to stop me if you want to ask me a question during the course or afterwards. Here, basically the polarity of P wave is upright in leads 1, 2, and 3 in AVF. Remember that. And the polarity of Qrs complex is upright. It depends upon the leads, which leads they are. Remember one basic principle. If the cardiac vector is moving towards a lead, it will register it as a positive deflection. And if it's moving away from the lead, it will register it as a negative deflection. For example, the cardiac vector, as I said, if you just draw a clock face, it is from 11 o'clock position towards 4 o'clock position, right? It is from the right arm going to the left leg. Now, the leads which are looking on this side, they are looking from this side, and the vector is going this way. So therefore, this vector, when it is going towards those leads are the inferior leads, they will register the cardiac vector as positive deflection. And because it's going away from this arm, so the right arm lead will be registering it as a negative deflection. So in AVR, you will see the P wave as downwards, because it's going away from the AVR and it's going towards the left leg. So the inferior leads, this is the inferior lead area, 1, 2, and 3 in AVF, and that will be registering as a positive deflection. Similarly, the cardiac vector itself is going away from the right side, so all the Qrs complex will be negative as a rule in the AVR. AVR is profoundly negative. Everything is negative because the cardiac vector in a normal person is going away. And if that is positive, it means there's a very big problem. There's a swing of axis and there's superiorly directed vector. So that's abnormal. Right. Basically, the first initial deflection, which is negative initial deflection, is called Q wave. It is called QRS because it is the ventricular depolarization signal. But it doesn't have to be Q, R, and S. 3 components may not exist. It may be only R and S, but it's still called QRS because it is just basically, as a routine, as a norm, people started calling it as Qrs complex. But if there is no negative, look at this is the positive baseline and there's a negative deflection there. Now this negative deflection is Q, small q. And small q is written as a small q, and then this is a positive deflection which is very big, and that first positive deflection is called R wave. So first negative deflection is called Q wave, first positive deflection is called R wave, and then there's a second deflection that comes down here that is called S wave. So second negative deflection. The first negative deflection is Q wave. The second negative deflection is called S wave, right? Sometimes there's no Q R wave, there's only Q and S. Q, and S. So there's no R wave in some of the cases. So you may see RNS, you may see QRNS, you may see QNS. There may be no R wave. So, but it is still called Qrs complex because it represents ventricular depolarization. That's all. Just it represents ventricular depolarization. The changes within that depolarization would depend upon the particular lead. But we are still going to call it Qrs complex. Right? And then ST segment is the segment that is between the S wave and the T wave. Usually it is isoelectric. It should be at the baseline. It should be isoelectric. And the T wave is a positive deflection which represents the ventricular repolarization. So ventricular repolarization is basically T wave. U wave is a positive deflection after the T wave, and it is thought to represent, it is thought, it's not very clear, but it is thought to represent the after depolarization. After depolarization is a terminology in electrophysiology that will come to here later on, but just remember it is thought to represent after depolarization. This is repolarization. ST segment is the refractory period, absolute and relative refractory period, and this is the ventricular depolarization, and this is the atrial depolarization. So this is the nomenclature that we'll be hearing. And now coming back to the P wave. What is the duration of the P wave? How big that should be with the normal range? So coming to the practical things rather than theoretical, in adults it is, upper limit is up to 200 milliseconds. 200 milliseconds. In other words, how much? 5 small squares. Up to, from here, from the start point up to the start point of the Qrs complex, that's the PR interval. In adults, it is 200 or less, between 120 to 200 or less. If it is less than 120, it will be called pre-excitation, because it is not through the AV node, it's bypassing the AV node. The delay in the AV node basically is causing this PR interval, right? In the AV node, atrioventricular node, you know there's a delay there, and that delay is represented on the paper as PR interval. And if that PR interval is shortened, it means it's not going through the AV node, it's bypassing the AV node, and that's called pre-excitation. And there are 2 or 3 syndromes such as WPW syndrome, Wolff-Parkinson-White syndrome, and one of the ECG that was shown delta wave, that slurring on the upstroke, was WPW syndrome by Dr. Masood. So you have to look at this PR interval. The normal interval is from 120 to 200 milliseconds. That is, it should be 3 to 5 small squares. 3 to 5 small squares. Yes? 3 to 5 small squares. 3 squares is 120 milliseconds. And 5 small squares is 200 milliseconds. So the normal is between 3 to 5 small squares. Right? And if it's bigger than 5 squares, obviously PR interval is prolonged. It means there's excessive delay in the atrioventricular node. The delay that is more than normal, excessive delay. For example, that happens in rheumatic heart disease. For example, that happens in some of the drugs that we use like digoxin. So first degree heart block basically is excessive lengthening or prolongation of the PR interval. Qrs complex. What is the duration of the Qrs complex? Yourself? Qrs complex?
0.12 seconds.
Right?
0.12 seconds.
Absolutely. The upper limit is 0.12 seconds. In other words, let's call it 120 milliseconds. Yes? 120 milliseconds is how much? 3 small squares. 3 small squares. So it should be, the duration of that should be less than 3 small squares. less than 3 small squares. So that's the duration of the Qrs complex. And then T, Qt, another important duration is, or interval is Qt, because that represents the refractory period, because that is the repolarization here, that's the refractory period. So the longer the interval, the refractory period, the greater the chance of getting some trouble or arrhythmias. Prolongation of the Qt interval is associated with ventricular tachycardias or ventricular fibrillations in certain cases, in drug-induced cases, in congenital cases. So therefore, you have to remember Qt interval. Qt interval has to be adjusted with the heart rate. QTC, it is called QTC, C for corrected. So it is corrected for the heart rate, and you have to adjust that according to the heart rate. I'll come to that in the next few minutes. So remember the Qt interval, remember Qrs interval, remember PR interval. You have to know the norms, and the norms that I've given you, they are for adults. For pediatric patients, the PR interval can be normal up to 220 milliseconds. So up to more than 5 or 6 small squares. Less than 6, but basically more than 5 small squares. Next. Can I just go back for a minute? Yeah, go back. If you look at this one, basically it tells you the same thing. One small square is 40 milliseconds or 0.04 second, and if you have an aggregate of 5 small squares, which makes a big box, that's basically 5 multiply 0.04, and that becomes 0.2 seconds, which is 200 milliseconds. Yeah? Got it? It's just basically the same thing. There is a 5 times this is equal to 1 big box. So if you look at a big box, you know it's 200 milliseconds or 0.2 seconds. Next. Pardon? It should be isoelectric, usually isoelectric, but we'll come to that. It's just basically diagrammatic. It's not the actual one. Next. Right. This is ECG waves and intervals. I think I've gone most of that. What do they mean? The P wave is the sequential activation of depolarization of the right and left atria, right? So it's both atria, right and left, they are represented. There's basically summation of the electrical forces that are directed in the atria. Summation of that is the vector. It's got a direction to that. And that is the P wave. Qrs complex, right and left ventricular depolarization. Normally the ventricles are activated simultaneously. Which one is the right? Which one is the first to be activated, right or left? Right?
Practically speaking, it is right. We say that they are stimulated at the same time. Actually, it gets a little bit early.
Which one?
Right one.
Right. It's the postrobasal portion of the septum that is activated first. Remember that postrobasal portion of this. Last time when I was here, I think I brought the model to show that the septum between the two ventricles, the postrobasal portion, which is at the back, which is close to the left atrium, that's the area which is activated first. And from there, it is directed towards the right ventricle. So it is directed towards the right ventricle, starts from the postrobasal portion of the septum, and then the right ventricle is activated first, and afterwards, because the left ventricle is bigger and meatier, therefore it takes over and you get more electric force directed towards the left ventricle. Right. STT wave, ventricular repolarization, this one. Next. U wave, origin of this wave is not clear, but probably represents after depolarization in the ventricles. So U wave is basically after depolarization in the ventricles. It follows T wave as always in the same direction as the T wave. It is usually found in patients who are bradycardiac, not in patients with tachycardia. It's very difficult to find it. PR interval is time interval from onset of atrial depolarization to the onset of ventricular depolarization. Qrs duration, we've done that. QT interval is the duration of ventricular depolarization and repolarization. The QT interval is both ventricular depolarization and repolarization. RR interval is the duration of ventricular cardiac cycle. Duration of the ventricular cardiac cycle, that is the one beat. And PP interval is duration of the atrial cycle, the indicator or atrial rate. Next. Orientation, I think I've gone that one. You've been shown by Dr. Nasir Shah. I don't need to spend time on that. Next. This is important. I think bipolar leads, they are called, limb leads are called the bipolar leads. Yes? Right arm, left arm, right leg, and left leg. Those four leads, they're called bipolar limb leads. The unipolar limb leads, they are the one on the chest. They're called chest leads or unipolar limb leads. Just for the sake of, you'll come across these terminologies. Now, I don't think you need to spend time between this one, the right arm and the left arm. Basically, it tells you the lead 1. And between right arm and left leg is the lead 2. And left arm and the left leg is the lead 3. You don't need to remember all that. I think it's basically for somebody who's just going for... You need to just remember that bipolar limb leads are the limb leads. They are bipolar because there's a differential between the two limbs, and therefore they're called bipolar. And unipolar, they're just on the chest, right? So unipolar limb leads and bipolar limb leads. Next. If you go back for a sec. Now this one is very important. This is called hexaxial system to understand the axis. I think we'll come to that, but it's just basically tell you that this is 0, this is 180 degrees, this is 90 degree positive, and this is also 90 degrees here. And if you go from here to this side, you basically you go negativity towards the negative side, and you go this way, you go the positive side. Normal cardiac axis is minus 30 to plus 90. So that's the normal cardiac axis, minus 30 to here. That is for adults. For pediatrics, it can be different. And if it falls outside here, we call it left axis deviation. If it falls outside here, we call it right axis deviation. Next. Next. How to measure the heart rate, basically. Next. Next. Right. Now, I think it's a little bit fuzzy here. It'll be difficult for you to do the exercise here, but basically how to calculate the heart rate on this ECG, for example. Can somebody volunteer? I've told you that there are 25 small squares in 1 second. So how many small squares in 1 minute? Times 60. 25 times 60. That is 1500. Right? So if you basically 25 small squares in 1 second, the ECG machine is just running it at the speed of 25 small squares. So it's just basically, it gives you the paper 25 small squares. So in 1 minute you'll get a paper with 1500 small squares. Yes? Now if you have the RR interval, if you have a paper which is got 1 minute paper, 1500 small squares, and then you count the number of this, you can get the heart rate per minute, but it'll be time consuming. So what we do is you just take, if it's a regular rhythm, you take the interval between RR to RR complexes or RR interval. Let's say this is let's say this is how much? 30? Let's say these are 30 small squares or 5 or 6 big squares. If it's a 30 small squares between these two, what's the heart rate? If it's a regular rhythm, 1500 divided by RR interval. 1500 divided by RR interval. So that is your heart rate. So heart rate is either 1500 divided by RR interval in small squares or 300 divided by RR interval in big squares. Big square is how much? 5 small squares is a big square. So 1500 small squares will be 300 big squares. So either you do a 300 big squares divided by heart rate, RR interval, or 1500 divided by RR in small squares. For example, in this one, let's say if you calculate from here to there, let's say there's 40 small squares. And the 40 small squares, 1500 divided by 40 is equal to your heart rate. Right? Let's say it is 30, and then 1500 divided by 30 is your heart rate, 50. Let's say it is 20, it is, or 25, so 1500 divided by 25 is your 75 heart rate per minute. But you have to make sure that it is a regular rate. This and this, they are equally distant, not like atrial fibrillation. In atrial fibrillation, it's irregular, so you cannot compute it on the basis of 2 RR intervals. You have to take a longer step, 10 seconds. Usually the modern ECG machines, they are equipped with a trace at the bottom, and usually that strip is from there to there, 10 seconds. How much? 10 seconds. So if you count the number of complexes here, 1, 2, 3, 4, 5, for example, there's a 1, 2, 3, 4, 5, 6, 7, 8, and times 6. So if it's 10 seconds, 8 times 6 will be your heart rate. 8 times 6 is equal to, or 9 times 6 is equal to 56. Yes? What I'm trying to make clear to you is that
refreshment break after 5 minutes.
If we basically compute the heart rate, it's a lot easier to remember that you either do it 1500 divided by RR interval in small squares, or 300 divided by RR interval in big squares, or the latest paper ECGs are 10 seconds across. So if you just count the number of complexes here and divide it by 6, multiply it by 6, that will be your heart rate. Okay, can we go back? So heart rate basically is, you can state the heart rate, atrial heart rate and ventricular heart rate in sinus rhythm should be the same, because basically each ventricular beat is preceded by the atrial contraction. But it may not be the case in cases of AV dissociation. And you need to remember only 2 cases of AV dissociation in which the atrial beat is not getting through and is not one-to-one relationship with the Qrs complex. If the atrial rate is faster than the ventricular rate, it is called complete heart block. Right? If the atrial rate is faster than the ventricular rate, usually it is the heart block, AV block. It could be 2nd degree or 3rd degree, but it's the heart block. And if the atrial rate is slower than the ventricular rate, it's called ventricular tachycardia. So AV dissociation will be there. But you have to remember heart rate, atrial and ventricular. Atrial ventricular is one-to-one relationship in most of the cases. PR interval, I've told you that. Qrs duration, we've gone through this. Next. Basic rhythm. Is it a normal sinus rhythm? So then after doing the heart rate and doing the basic intervals, you need to know the rhythm of the heart. What is the normal rhythm? The normal rhythm of the heart is sinus. What is sinus rhythm? One-to-one relationship. Each P wave should be followed by Qrs complex. That is the sinus rhythm. Right? And atrial fibrillation, when there's no one-to-one relationship, the atria, they've got their own way of contracting, the ventricle, they are doing themselves different. So whether it is atrial fibrillation or whether it is like complete heart block or whether it is ventricular tachycardia or junctional tachycardia, but that's not sinus. Sinus rhythm is one-to-one, P to Qrs complex, one-to-one relationship. Each Qrs complex should have a P wave preceding that complex. Identify additional rhythm events if present. For example, PVCs, this is premature ventricular contraction, premature atrial contraction, so you have to identify that in the ECG. And consider all rhythm events from atria, atrioventricular junction, and ventricles. In other words, either it will be a sinus rhythm, or it will be a nodal rhythm, or it could be ventricular rhythm, or it could be another one, which is basically called due to functional disturbance in the AV node. That's called re-entrant tachycardias. Different. Next. Now, conduction analysis. You have to look at the conduction. PR interval. We have discussed it. If the PR interval is longer than 200 milliseconds, that is called heart block. First degree heart block is lengthening of the PR interval. So the abnormality lies in the AV node. For example, due to inflammation, such as rheumatic fever. It could be drug-induced. It could be the block at the level of sinoatrial sinus node. Sinus node is at the junction of superior vena cava with the right atrium. And if there's a block in the sinus node is discharging, but it is not getting out of the sinus node, it's called sinoatrial block or exit block, right? And that will be seen on the ECG. AV block is in the AV node, which is basically just before the bifurcation into bundle of his. This is the AV node here at the tricuspid level, and that can lead to first degree heart block, second degree heart block, or third degree heart block. First degree is PR interval, prolongation of the PR interval. Second degree is of two types. What are the types second degree? Wenke-Baching and Mopitz type 2. Wenke-Baching is progressive lengthening of the PR interval followed by drop beat. In other words, the AV node is getting tired. It allows you to basically transmit the atrial impulse initially at a normal rate and then progressively getting stressed out, so you get progressive lengthening of the PR interval until it cannot conduct, so there's a drop beat. That is Mopitz type 1 or Wenke-Baching. So that's second degree heart block, Wenke-Baching. Second degree heart block type 2, Mopitz type 2 is 2-to-1 block basically. 2-to-1. One beat is being dropped. Every second beat is being dropped. So that's a second degree heart block. Type Mopitz type.
It's a first degree heart block. PR interval is same, although it's prolonged.
Yes. It will not change, should not change. This lengthened PR interval, more than 200 milliseconds. And in second degree heart block, Mopitz 1, progressive lengthening. So it may start off as a normal, next bigger until there's no beat. And then recycle starts. And the third degree heart block is complete AV dissociation. There's no relationship of P and Qrs complex. So therefore, the ventricles, they are either having a junctional rhythm or idioventricular rhythm and not a sinus rhythm. Right? So that is the abnormality of the AV node. Then branches. These are after AV node. You got bundle. Left bundle and the right bundle. Left bundle and the right bundle. Right bundle is very simple, but the left bundle again subdivides into two: anterior fascicle and the posterior fascicle. So left anterior fascicle, left posterior fascicle. On the right side is the right bundle, right? And there could be block in that leading to right bundle branch block, left bundle branch block, or left anterior hemiblock or left posterior hemiblock, according to the area of block. Exit blocks are blocks just distal to the ectopic pacemaker site. Very simple. That although it is impulse is being generated, but it is not spread out. So there's a block at that. It could be due to different disease conditions, but that's called exit block. So in other words, Conduction abnormalities can start at the sinus node. They are usually called sinoatrial block or exit blocks. They are the commonly found ones that you probably will be interested in is the AV nodal block. And first degree heart block, second degree heart block, third degree heart block. More importantly, second and third degree heart block, especially in patients who are symptomatic. For example, young patient who has got complete heart block, we'll show you the ECG, but that has a meaning because that patient needs a pacemaker. So if you identify complete heart block in a young patient, female or a young boy, the patient needs pacemaker. Whereas a patient with heart attack, myocardial infarction, inferior has got complete heart block, and you found patient desperately needs emergency temporary pacemaker implantation along with the standard treatment for heart failure, for myocardial infarction. So anterior myocardial infarction with complete heart block or heart block is dire emergency because that patient is probably going to arrest any minute. Right? So therefore, identification of the heart blocks is important, in particular in young patients without symptoms or symptoms. They may need pacemaker, or in the context of inferior or anterior myocardial infarction, because those patients are at very high risk of developing complete heart block or asystole, and they need hospitalization and temporary pacemaker implantation. Next. Right. Attentiveness, it is the most boring part of the ECG that you've been listening to. It will continue to be a little bit more boring for the next 10 minutes, and then we will go into the interesting bit, which is interactive session. So this is just basically a run-up to interesting bit when we'll start looking at the ECG and the problems and solve the problems. It is just basically a dry, a boring bit of the ECG. You have to bear with it for the next few more minutes. Now, P wave. Basically, how you look at the waveform. This is very practical. So what we've done so far is basically to look at the ECG as an electrical summation of forces coming from the heart. And they give us very valuable information about the activity of the heart as it happens, electrical activity of the heart as it happens. We have identified P waves, Qrs complexes, and T waves. We've already got some idea about the PR interval, which is 120 to 200 milliseconds, 3 to 5 small squares. The Qrs duration is important, and that should be less than 3 small squares, preferably 110. If it between 110 200, it is called partial branch block. And then the QT interval is important, and we should be able to do that, compute that one as well. So these are about intervals. Now, the P wave morphology. Do they look too wide? Are they too tall? They look, funny. Now, the significance of that is because it is the combination, is a sequential activation of both atria, right and left, that give us the P wave. So if the right atrium is enlarged or the left atrium is enlarged, it's going to give us abnormality in the P wave. So bifid P wave, broad P wave, is usually seen in the left atrial enlargement, and it is not uncommon to see patients with mitral stenosis to present with a bifid P wave or biphasic P wave in lead 1, V1. The best leads to look for P wave are inferior leads, lead 1, 2, 3, AVF, and V1. The best leads to look for P wave is lead 1, 2, 3, AVF, and V1. Remember that. It should be in a sinus rhythm. In a normal subject, the P wave is always upright in leads 1, 2, 3, and AVF, and it is negative in lead AVR because it is going away from there, and it can be biphasic in lead V1. It could be upright could be negative, it could be biphasic in lead V1. Remember that. That's very useful. If you remember that, you'll be able to